So I'd like to thank you for letting me into your living rooms. My name is Dr. Isaac Towell, and I am a general dentist in Brooklyn, New York. I've been practicing for 13 years, and one of my primary focuses is on dental implants. I believe some of you may have seen my last webinar on Osteo News, which was about how to treat the lower mandibular deficiencies. Basically, it was a ridge splitting topic. Today I'd like to pick a different topic, something that many of us, not just general dentists, surgeons, periodontists, we all encounter this every day, where we have these failing molars. And these molars are typically taking longer because we have to graft and then come back, and sometimes it can take upwards to a year just to restore. So in this presentation I'm going to try to show you some of my techniques as to how to do immediate molar implantations, and as well as using the natural tooth as a surgical guide. So again, this is my office in Brooklyn, New York, in the bottom corner there, and we'll be going over the immediate molar implantation. Just as a disclosure, these are some of the companies that I've lectured for over the years, and I will be showing some of their products. Although I have no financial obligation to them, I do like their products. I do use their products, and I will be showing some of them throughout this presentation. So this is one way to do immediate molar in our practices. This guy got a little too implant happy. I guess he was trying to charge for pretty much everything he can do. I believe this is a fake, and I really hope it is, but this is one way to do it, and you can actually do these with mini implants. A lot of people have shown that. They have some good success. I'm just not into the cantilever effects that are caused by them. And in this type of x-ray, you can look, the cleansability has to be quite difficult, and so I'll show you the more preferable way for myself as to how to treat these. So what are our options after extracting a multi-rooted tooth? Well, we can delay the implant placement until the soft tissue is healed, and then we can come back after the bone is healed and place an implant. Sometimes we'll have to do a bone graft. We can preserve the socket in anticipation for that bone loss, try to keep what bone is available to us, then come back and go ahead and place an implant. Or we can try to place a super wide implant, which used to be what I was preferably using, these wide rescue implants from Megagen. Some of you have seen other companies such as Implant Direct with their wide implants. They're pretty much everywhere these days. I've been shying away from them. I think too much titanium is not good. I'd rather have less titanium and more natural bone. Last one is a immediate placement of a regular platform implant, and again, you can do that in a single stage or a two-stage approach. So, what is the disadvantage of delaying by not placing a bone graft or an implant? So we will have aesthetic problems because we'll have some tissue loss, some bone loss, some resorption of the buccal plate, and as well as having to place the implant more lingually. I'll show an example of a slide of that in a moment. But if we're going to place the implant more lingually, then we're going to end up with a cantilever effect. So one of my favorite studies was done by Arroyo, showing what happens to the buccal plate after extraction. So as you can see here in this slide, if you focus on the upper right, we have at 1 week after extraction, we have some remodeling occurring. And we have some cortical bone, some bundle bone being formed. And what we're going to be following is that upper, on the right side of our screen, what happens to that bone as we keep going. So at 2 weeks, you can see that the buccal bone is starting, the cortical bone is starting to change. We're getting a shift here, and it's becoming more pointier. And that's only at 2 weeks, meaning that we're losing some of the buccal plate. You can see on the left side of the screen that magnification of the buccal wall at the crest, and you shift over to the right, you can see that there's a lot of remodeling occurring and that there's losing some vascularization. And then after 4 weeks, you can see the buccal bone on the right side of the picture there, where the arrow is actually below the lingual plate now. So we're already losing that buccal bone. And finally, at 8 weeks, you can really see the distance between the buccal and lingual bone. So basically, the concept that we should be taking home from here is that if we don't do something, then we could end up in this type of situation where we lose a lot of buccal bone. So the dimensional ridge, basically, if you follow the slide on the left, where we have the levels that were taken from the buccal wall and the lingual wall, at different intervals. And if you look at the 8-week interval, we get an average loss of about 2 millimeters to the buccal plate. So what happens in the delayed approach? Let's take this example here. We have a tooth that is non-restorable. As you can see, after the 8 weeks of healing, in this type of case, it was probably a traumatic surgery. I can't recall exactly, but it was probably traumatic, and we did lose the buccal plate. That's not to say that if we take out a tooth atraumatically and leave it alone that it won't form fine. But as a whole, usually a atraumatic extraction does have some trauma to it, and we do lose some of that buccal plate. So our options are really to go ahead in this type of situation and place the implant more lingually, which is something I'm really not a fan of, because what will end up happening is we'll end up having a big buccal cantilever. It'll be hard to clean, or we'll have to make a really, really small crown out of this. As you can see in this type of case, what I've done to try to preserve this case was to reposition the tissue. It's a folding technique where we would take the inside of the we would take the outside of the keratinized tissue and just try to clean it off a little bit as if you were doing a connective tissue graft, and then fold it over on the inside and then overlap it so we can get some tissue thickness back. And then you can see here, it's not, we got a little more keratinized tissue on the buccal. Again, lingual placed abutment. Finally, the crown is placed there, and you can see on the buccal that there'd be a nice size cantilever, a good food trap, which a patient would not be really happy with. So, if you can see the difference between the two sides, one is a natural tooth on the right side, and the left side is the implant crown. That's basically what we would expect, that to have a smaller crown, not the same size as a natural tooth, and to lose all that buccal plate in the delayed approach. So our guidelines for immediate molars. Well, first off, we'd want to have no active infection of purulent exudate. That's not to say that a cyst cannot be there. I've treated many cases with a cyst. As long as it's not abscessing, where there's no exudate coming out, I'm very confident treating those. If it's your first case, I wouldn't necessarily choose that as a first case to do an immediate molar on. But if it's if you've had a lot of experience with it, then there's no reason why some cystic tissue should really be stopping you. The ideal buccal lingual dimensions is very, very important. You want to leave at least 2 millimeters on each side. Again, that's at least 2 millimeters on each side. So preferably we want, for a molar implant, we'd want to have 2 to 3 millimeters on the buccal and 2 to 3 millimeters on the lingual to prevent future resorption. An atraumatic extraction, I'm not sure if that's actually something that actually exists. An atraumatic extraction, I would say a minimally traumatic extraction would be a better term for it. But we do want to have as little turnover of the bone, and by preserving the buccal plate, preserving the surrounding bone, we would classify that as an atraumatic extraction. We want a distance from the inferior alveolar canal of at least 2 millimeters. Radiographically, so that we don't create any trouble with the IA, any paralysis. And the implant must be 2 millimeters apical to the lowest crest. These are for bone level implants. If we're dealing with tissue level implants, it's a completely different situation. My preference is to use bone level implants in these cases, and I want them at least 2 millimeters below the crest. That is just one portion of it, because we also have to account for the fact that we want 2 to 3 millimeters from the buccal plate, because we want to be able to preserve that buccal plate, have it intact, and then leave a little gap of 2 to 3 millimeters from the end of the buccal plate so we can account for resorption. We never know when a case is going to decide to resorb a little too much, so we want to leave that extra room so that we can preserve, in the end, at least 2 millimeters of buccal plate. An intact septal bone is very important for a regular platform diameter. If we're using super wide diameters, that does not apply. But if we have good septal bone, we can get great primary stability, and we'll be able to treat the case in a quicker fashion. Divergent roots are very helpful for those regular platform implants. If the roots are not diverged, if we don't have that septum, then super wide implants can be used. I've been shying away from those. Again, it's not to say that I haven't placed some here and there, but as a general rule, I try to use regular platform, anything for a molar, anything from 4 to 5.5 millimeters in diameter, as much as even 6 millimeters in diameter. Okay, so popular implant sizes. For a mandibular anteriors, we typically use 3.5 millimeter implants. Some people are using one-piece implants that go even narrower than that. For maxillary anteriors, I typically use 3.5 to 4.5 millimeter implants. And for molars, we usually go 4 to 6 millimeter implants. And then there are the extra wides. The ones that I use are from Megagen Rescue implants, and now the wider AnyRidge implants. They go 6 to 8 millimeters in diameter and width. But again, I've been shying away from that, staying more towards the 4 to 6 millimeters for the molars. So this is the Megagen product line, and this was the old line where we had the rescue implants for molars, Easy Plus implants for premolars, and then there's some one-piece implants called the Intermezzo, which has since been replaced with the Any1 or AnyRidge Mini implant, which I use typically for lateral incisors and for mandibular anterior implants. So for the rescue, this was the old protocol, how we used to do it, and I'd like to take you through this just to show you how we used to treat with the extra wide implants. We used to take a treff line with a stopper. That little blue piece over there was a stopper, so we'd be able to control our depth. And then we would use a pilot drill just to clean up the excess, just in case there was any extra bone at the bottom, towards the apical portion, and as well as just finishing up our osteotomy. And there was an option to use a bone tap if it was in really dense bone. And then finally you go ahead with the fixture placement, and that typically was placed between 35 to 40 newtons and placed 1 millimeter subcrestal. So here's a case that I was treating, and you can see on the lower left corner that there was a infection there. Was diagnosed as a fracture, so by endodontist, so we decided to remove the tooth. And as you can see in this case, we removed the septal bone there. Once we took out the implant, there was pretty much no septal bone left, and then we placed the implant slightly pallidly in this case, but you can see the extra wide implant and leaving enough room on the buccal plate. From the buccal plate, we're actually engaging the septum, if you notice there on the buccal, to help stabilize our implant. And we pack some extra bone graft around it and place a super wide healing abutment. That's an 8 wide by 3 length super wide healing abutment. It helps make easy use for primary closure around the implant. And you can see on the x-ray, this is at 4 months, and we're getting good healing. And then at 4.5 months, we decide to take an impression using a transfer, and you can see on the lower left we have the final crown. And there you can see the upper left corner as the post-op final 4.5 month x-ray, and then you can see the 1 year follow-up on the bottom showing a good emergence profile and nice size crown. But do we really need to use these wide diameter implants? They seem to be growing in popularity, but in today's day and age, the titanium has really been phenomenal. These grade 4 titanium implants have been giving us some real great strength. The ability to use platform switching took away the need to use such wide diameter implants, and we can preserve more of the bony architecture and have less titanium, which I think is a better way to go. So by using a minimally invasive, more efficient implant, we can begin to save that buccolingual crestal bone. So if we look at these different implants here, you can see on the left we have a wide diameter 6 millimeter implant, and it's basically cutting the corner on that buccolingual crest. Same thing where we have another super wide implant from another company where, again, it's impinging on that buccolingual bone crest. So if we can use a smaller implant with a narrower fixture, so something like a 4 millimeter, 4.5 millimeter implant that has a 2.8 millimeter fixture but extends its threading to give us better primary stability and yet give us the same strength, that would be a great way to be able to treat our patients. So we can increase our chances of flapless surgeries in these cases as well. So the ideal concept for the ideal fixture would be a tapered implant with a narrower apical diameter, to have limited crestal width, so again we can preserve that buccal lingual dimension. And in this case you see this implant doesn't fit the bill. But if it's cut back a bit, which there are a few other implants that do that, we would be able to preserve that buccal lingual dimension. But again, this type of implant, even though it's cut back, does not cut back enough at the coronal portion. And again, another implant that's cut back, but again, not cut back enough at the coronal portion. It's cut back more in the middle third. So ideal design would be to have a narrower fixture with wider threading to be able to engage that cortical bone. So the AnyRidge was created. I've been using this implant for 4 years now, and I've been really fascinated by what I can do with it. It is minimally invasive, and it is more efficient because of the fact of this one platform for all. So going from 3.5 millimeters all the way out to 8 millimeters in width, we can use the same abutments and be able to platform switch our implant. So just one more touch on is the threading design. Those round threads give us a bigger surface area, which basically gives us an increased cutting efficiency during insertion and giving us better primary stability, as well as increased resistance to compressive forces. Because of those wider threading, we get less micro movement of the implant. In addition, we get minimized occurrence of shear forcing and a higher bone implant contact. So if we look at this diagram here, and this is my diagram to convince you that a 4 millimeter implant is just as good as a 5 millimeter implant in terms of width. And if you would place a 5 millimeter implant for a molar, then you should be able to place a 4 millimeter AnyRidge implant with the same size. If you look at the compressive force on study from this implant, you can see that the 4x10 and 5x10 are actually equal. As a matter of fact, the 4x10 is a little bit stronger than the previous Easy Plus system that we used to use with the Megagen implant system. So what are our options once we plan on doing an immediate molar? We have basically two options that I would use. There may be many others. But we can either extract and drill. And when we extract and drill, we end up with complications with the extraction sometimes, and I'll show you what I mean by that. The drilling difficulty, because now we're trying to engage the septal bone, and the burr just starts wobbling all over the place, which leads us to an improper implant placement and poor angulation, and it's longer time-consuming than if we decide to drill and extract. I find that it's much simpler to use a tooth as a surgical guide. It's faster. We get better emergence profile because of the fact that we're placing it in the correct position, and we preserve more bone doing that because we don't have to use such a large amounts of drilling. And in addition, we get better function long term, and again, that leads more towards the proper positioning of the implant. So this is the AnyRidge drilling kit, and it is compiled of step drills and a lance drill to start. There is an option to purchase a Lindemann drill, which is my favorite drill. I use those routinely in these types of cases. They do have depth stops on them, which really help in these cases as well. And we'll take you through that step by step. So our drilling choices. So for me, again, there's just two drilling choices for this type of a case. There is the Trefline, which I showed you before at the rescue, has a stopper on it. And there is a Lindemann drill. And the Lindemann drill, again, is my choice, but I'll show you both ways of how we can treat it. So in this case, we had a patient present to us with a fracture, and we decided that we were going to go ahead and remove the tooth. So we extracted the tooth first, and we atraumatically extracted that by leaving the buccal plate intact. And then we went ahead and used our Trefine. And what's nice about the Trefine is that we do get to harvest all this bone. So we don't have to open up a jar of allograft in many situations. And we can go ahead and pack that into our defected site there. So we placed our implant. We placed our graft material all around it. You can see the extra wide threads on the implant, on that any-ridge implant. Gave us great stability, and we packed our bone around it. And that's a 5.5 by 11.5 millimeter any-ridge implant. Then we went ahead and used our extra wide healing abutments. This is an 8 millimeter wide, 4 millimeter length healing abutment. Again, that gives us good primary closure. You can see around it there is some PRF material. The material I use is actually CGF from Silfrident, and that allows me to create a natural blood membrane instead of having to use a cow membrane or whatever your choice of membrane may be. And you can see at 2 weeks we actually have some overgrowth of tissue. At 4 months it's looking really well. We could use a taller healing abutment at this point. Usually I would expect to see some gingival reception in the area, but in this case the patient just responded really nicely, so I went ahead and switched the healing abutment, and again ended up getting a nice soft tissue emergence profile and a nice crown. And on our final x-ray you can see the abutment in place and our final crown. And this was all done in a 4-month, within 4 months. And the 1-year follow-up, all is looking well, and the implant is very, very stable. So I'd like to present to you what I call the human surgical guide. I've been using this technique for many, many years. I've been seeing it growing in popularity over the last few years online on various dental implants websites and on various blogs, all over Facebook. And I think it's important to learn this technique because I really feel that today surgical guides are becoming more and more used, and I'd like to show you how to use a poor man's surgical guide, which is using the natural tooth of the patient. So in this case, again, we're diagnosed with a fracture with a apical periodontitis. And you can see on the coronal slicing we have plenty of width. It's 10.4 millimeters on buccolingual dimension. And our distance from the IA, I'm not going to place longer than a 15 millimeter implant, so we have nothing to worry about there. So we go ahead and we start by sectioning the tooth, and I'll show a video of this later, but we'll section the tooth from the buccolingual dimension, and then we'll go ahead and we'll use a Lindemann drill to drill right in between the septum. Once we've used a few step drills, which I'll show you on the video later, we can then see that we can extract the tooth a lot easier, and we get our great angulation. You can see here the guide pin is in place. We have very nice access to the septal bone. And we'll go ahead and place our implant, and we're getting an Ostell Reading. This is the Mega ISQ. I have it's made by Ostell. I have both the Mega ISQ from Megagen and the Ostell unit in my office, and they both work the same. They both work very well, and they give us great readings along with our torque value. If we have a torque value of 5 newtons and we get a great ISQ reading, that does not mean that we should be loading that patient early. I think they go hand in hand, and I think you're seeing that more and more in various different articles and various different implant journals, that high torque value with a high Ostell reading leads to great success. So in this case we got 75. Anything above 60 I will second stage. Above 70 I will go ahead and a lot of times restore, but not molars. It would be more in those anterior cases. And again, that is implant specific by manufacturer. I would not just go by these numbers. Contact your implant manufacturer and find out what Ostell readings that they recommend. So you can see the implant is in place. We decided to place some bone graft. This is an allograft material around it. And you can see on the bottom corner there, that's what happens to my bone graft material when we put it with that our growth factors, the product from Silfreeden called CGF has a yellow tube as well, which you can spin, and once it's spun, you can harvest the fibrin from it, and it makes the bone very, very sticky. So that's the autogenous fibrin glue mixed with the allograft. You can see we can just lift it up, pick it up, place it right into the defects, and then just pack it till it fills the voids. So in this case, you can see again, we've utilized that extra wide healing abutment. That is some fibrin clot around it as well. And we can see we're going to get a nice emergence profile. If you were to imagine a crown on top of, instead of that healing abutment, you can see we've got a good emergence profile. And this was a 4.5 by 11.5 millimeter any ridge implant. And in many of these cases, I typically like to use just gut suture. So here's another case. This was a primary deciduous tooth. I like to show this one because I think it really shows the septal bone quite nicely. So this tooth was hopeless, so we extracted it and made our buccal lingual horizontal cut, and then went ahead and used our liniment burr and then placed our guide pin to confirm our angulation. And once you do that, it kind of frees up both the mesial and distal root. I really like sectioning all teeth that I extract, all molars that I extract, especially if once the roots are on their own, they're a lot easier to take out. So you can see there with our osteotomy in place, our implant in place, and then just filling the voids. Again, similar to the last case, it just shows really nice use of that septal bone. Again, the CGF clot around it, and that's just some gut suture as an X suture. And again, you can see how it heals quite nicely, fills all the defects. And again, this is a 4 by 11.5 millimeter implant, so we're getting narrower. So what about upper molars? It's basically the same exact technique. Again, the septal bone has to be available for us to be able to treat it. So you can see on the CBCT here, we have plenty of distance. We have about 11.5 millimeters before the sinus. We have plenty of buccal lingual dimension over here. It's about 12.4 millimeters. Again, the bone is a little softer on the maxilla, so we might plan on placing wider implants, but I typically like to place narrower style implants. So in this case, I just drew a little simulated implant there. And we're going to place the implants in those other sites as well, just to get an idea of what we would place, and that's a 5 by 10 shaped rectangle, excuse me. So after we section all of the 3 roots, it's going to be quite easy to elevate those out, but before we want to elevate them out, we're going to go ahead and start our drilling protocol. So again, that liniment drill was used first. We'd sink that down to a depth of 11.5, place our guide pin to confirm our angulation. And once it's out, again, you can see there the septal bone is really accessed nicely. So if we use too wide of an implant, we're going to destroy all that septal bone. We want to keep that septal bone intact because, again, that's the native bone. That's the strongest bone that we have in the patient. So we want to keep it, and we don't want to obliterate it. We want to really keep it and use it in our favor. And what I find is with using those super wide implants that we tend to destroy all that septal bone. So we'll get another Ostell reading. This is a 4 by 10 millimeter any ridge. And our Ostell reading in this case was an 85, which is very, very high, even for maxilla. So many people will say, oh, you need to use super wide implants or wide implants 6 millimeters at least in the posterior maxilla to get a great Ostell value, but you can see we got a great Ostell value just using a 4 by 10 millimeter implant. So we'll go ahead, we'll fill our voids, we'll place our CGF material, we'll suture everything up, and we'll let it heal up. And you can see again on the CBCT on the post-op, we've entered the sinus just ever so slightly, and we have excellent buccolingual positioning as well as mesiodistal. Okay, finally I'd like to show a case which was done in Vistara, which is in New Jersey. It is a facility run by Dr. Nicholas Elion, who is a brilliant dental physician and a world-renowned. His facility is absolutely top-notch, which provides learning programs of many different disciplines in dentistry. And we run courses there quite often. I have my own personal courses there once every 3 to 4 months, and this was a case that was treated in that facility, and we'll be going over the video. But before we get to the video, I just want to give you an overview of the case. So as you can see there, that our bite is very tight here. The patient needs full mouth rehabilitation but cannot afford it at this time, so she really wants to fill those 2 spaces on the lower left. That molar was treated. We tried to endodontically retreat it, which was causing a lot of pain, and when we did, we found that it was not restorable. In the area slightly to the buccal, mesial of that, we see that there is a deficiency of some buccal bone, so we're going to be doing some ridge expansion on that position to help facilitate for an implant. And in our CBT slicing, we can see as far as buccolingual dimension, we have plenty of bone, nothing to worry about. And in our cross section, you'll see we have a very narrow ridge on the number 20 site. Number 19 site is a lot better position. One thing I do want to mention, when doing this bone expansion or ridge splitting, we typically like to have these pyramidal type shapes, these triangular shapes, where it is wider at the apex than it is at the coronal portion, which allows us to be able to open the bone into a more squarer type of shape. So our molar position has no trouble whatsoever in terms of length and buccolingual dimension. Okay, so let's jump into the video here. So again, we're going to start by trimming down the tooth so we can be able to section it. And I find it's easier to cut it down, get it closer towards the gingival margin before we go ahead and make our cuts. It's easier to see. I think vision is paramount in these types of cases. So we'll go ahead with using a GW2 burr here. Just to cut it down, you can use a 558, whatever you like. You can see we're starting our sectioning of the tooth in the buccolingual fashion. And I don't drill this fast, it is a little higher speed in the interest of saving some time. So first we'll start off with the Lindemann drill. And we're going to use that to about a depth of 10 millimeters. And here we're just concentrating on the mesial distal position because we know our buccolingual is being guided by our roots. So the mesial distal root is going to help us into that position. And then we're going to go ahead and use our first step drill. It's a 2 millimeter step drill. In this case, this drill, you can see it's being blocked, but you'll see the next one a little bit clearer. That this drill does have a stopper on it, so we're going to sink it down to about 11.5 millimeters. We're not going to get down all the way to the septum. The tooth is blocking it, so that should leave us in about 6 to 8 millimeters in depth, and we'll go back ahead later and clean it up. You can start to see the osteotomy in the bifurcation area there. And now we're going to go ahead and use our 3.3 millimeter step drill. This one you can see a little bit better. This one does have a stopper on it. And again, the roots will guide us into the proper position, so we're only worrying about buccolingual dimension. And we'll sink that down to depth. Okay, next we will extract the tooth. This was a little difficult to get out the mesial root, as you can see, but elevating the distal wasn't so hard. Mesial decided to fracture when we were extracting it, but we were using the 2 roots against each other to help us extract, make the extraction a little simpler. So after elevating and we get some good movement, we'll go ahead and extract the distal root. And since they now became conical roots, and I know that there's no curvature to the root from the CBCT, we can give us some slight rotation in the buccolingual mesiodistal direction, and we can try to rotate that tooth out. And once that comes out, we can then go ahead and try to extract the mesial root. And it gave me a little bit of a tough time, and eventually we got it out. It took about 5 to 10 minutes extra to get that one out. And as minimally traumatic as possible to help preserve the buccal plate and as well as the septal bone. Again, we're going to rotate that tooth out. It does not have any curvature to it that we have to worry about the root tip fracturing. So we'll just keep rotating it, and it will pop right out. Following that, we wanted to bride the socket. Oh, actually, excuse me. There was a little root tip that was left in place there where the fracture was, which we had found, and it just popped right out after we had extracted the other portion. And you can see the osteotomy that was left there. We're going to go back in and lengthen our drill with our 3.3 millimeter burr and take it down to depth all the way to the septum. And those stoppers really help out a lot so that we don't have to focus on depth. And just cleaning up the remaining portion of the osteotomy. You can see I'm checking the buccal plate just to make sure that it's still intact. Okay, then we'll go ahead and debride the site. I'll clean it out, make sure there's no granulation tissue that's left behind. I think this is very important. We really do not want to have, you can see that little piece of tissue that can affect our future implant from not integrating properly. A lot of times I would even treat the site with some flagell to mix it with the bone graft material as well, but in this case we do not use that. And here you can see now we're sinking our implant down. It was the 4x10 millimeter any-ridge implant. You can see the threads are starting to engage quite nicely. And we're going to sink it down to depth until we get our torque value. And in this case, we got 40 newtons of torque. This is the Megatorque that we're using. It's a electronically controlled torque wrench, which is developed by Megagen. It's a wonderful tool. We're going to torque the Ostell smart peg in at 5 newtons. And we'll go ahead using the Mega ISQ. We're going to get our reading. And we do check every site. And then we got pretty much about 75 on each site, which means that we can go ahead and second stage. So now after we've extracted the tooth, I don't like to create a flap beforehand when I'm dealing with other cases because I want that periosteum to stay intact. But we'll go ahead and use a 15C blade to make our incision. Then we'll use a periosteal elevator or a molt or whatever your choice is to open up the flap and get access to that number 20 site, which was slightly deficient. And then we're going to go ahead and use a piezo. This is the saw tip from the piezo. And we're going to sink that down. You can see the animation in the upper corner. We're going to sink that down to depth. In this case, again, we want to go 10 millimeters. My favorite implant is a 4x10 millimeter implant. I like to use those whenever possible. The only reason for me to go wider would be to gain some more stability. And I'd prefer to go slightly longer, let's say a 4x11.5 rather than wider. And again, with this implant system, since it's one platform, the fixture diameter is the same, from 4 millimeters to 5.5. So the only reason for me to really switch to a wider implant would be if I had a extremely large patient with high masseter function, Bruxer, let's say, that I'd be concerned with, and get a wider fixture, which would be the 6 millimeters. So after our piezo, we are going to go ahead and use our step drill just to help create an osteotomy. You can use a piezo for that as well. Once we've used our step drill, we're going to go ahead and use the bone expansion kit, and we'll use a series of bone expanders to help widen the bone. And you can see the simulation on the upper corner there. We'll use our bone expanders to depth, and we'll take our time with them. We'll let them spin a little bit, let them set, and slowly allow the bone to expand. Once it's expanded, I leave it in there for an extra second or two, and then go ahead and remove it. Again, we're going with the wider expander now, and we may meet, I set these to 50 newtons, and when we meet the 50 newtons, I like to go ahead and take a torque wrench and slowly torque it down. This video is in fast forward, so it does look like I'm doing it a little faster than I usually do it. So we'll take it down slowly, but each turn, this is about 2 times speed but each turn should be a little slower, not to create too much compression in the mandible. In the maxilla, I'm a little more forgiving unless the bone is really thin, but in the mandible, we want to take it slow. So once that's completed, we'll use a cortical drill just to help us seat the implant. This is not always necessary, but in this case the bone is very dense, and we wanted to help make a simple pass of the implant, simple seating of the implant. So again, we're using another 4x10 millimeter any-ridge implant. You can see the blue coating on the implant is the X-Feel surface. It's similar to an SLA surface. It enhances osseointegration and allows us to be able to restore our implants a little sooner. And you can see here we're going to sink our implant to depth. And in this case, I do like to use water because of the bone expansion. I still worry about some pressure necrosis, and I find that using a cold bag of saline helps tremendously. You can see our implant is at the crest there. I believe we did use 1 or 2 turns more with the torque wrench, and we went ahead and took a Ostell reading. And in this case, we got an 80, which is very, very high. Typically, you'll find that in the mandible, especially in native bone sites, that will get a very high reading. We'll use the Megatorque to place our cover screws again. I like to place them in at 5 newtons. You can see there, cover screws in place in both sites. And then we're going to go ahead and use our FDDA mixed with that fibrin glue that we spoke about earlier. Again, the bone, just so simple. Just pick it up with a cause plier and just place in the area. And then just go and press it down a little bit, making sure to place some bone graft in the number 20 site on the buckle. I didn't decorticate in this area. I find that with ridge splitting, it is unnecessary to decorticate because we already have access to that medullary bone, which provides us enough blood supply for our graft to heal. Depending on what type of a defect it is, if I feel that I need a longer term membrane, a 4-month membrane, I may use something else, but in this case I felt that we had excellent expansion of the bone, and we didn't need to use a collagen membrane, so we're just going to use some PRF. Before that, we go ahead and place our wide healing abutments to aid us in primary closure. You can see the PRF material, that CGF material, on the wide healing abutment. These go in at 15 newtons. And you can see there it's locking in at 15 newtons. I like to put the PRF, just make a little punch hole with a rubber dam and help place the healing abutment in, and we'll place the rest of our CGF clots as our membrane. It's really amazing how this stuff really helps with soft tissue healing. You can see on the post-ops, things just heal really, really nicely and really quickly, and we get excellent soft tissue incorporation around our implants, leading us to great emergence profiles in the future. I rarely, in these type of cases with the extra wide healing abutments, rarely have any trouble with exposure of any the implants or graft material. So once the CGF material, we place about 3 or 4 clots in there. Once it's in place, we'll go ahead and suture. These are PTF sutures, Gore-Tex sutures. They're made by Osteogenics. In this case, we use a 4-0 suture, a reverse cutting needle. And we'll go ahead and just place some simple interrupted sutures. In this case, again, primary closure is a breeze around these extra wide healing abutments. And go ahead and tie our knots. I really like these Gore-Tex sutures. They really don't build up any microfilm around them, and they stay real clean, and simply just using a gauze to wipe them off a couple of days after surgery, they stay really, really clean, and it's very easy to tie knots around them. And once we've finished up our suturing, you can see that we have some excellent closure around our implants. You can see some of the CGF material is floating about. I have no problems leaving that exposed. Again, it really does help with the soft tissue healing. And primary closure around those healing abutments is just so simple. So once we get the post-op, this was at 2 weeks after the surgery. Again, you can see it's almost too good a healing. And this is what I find a lot, where I have to switch out healing abutments. I usually wait to switch them out, but we end up having to switch them out because of such a great tissue healing that things just try to build up around them. And then you can see at the 1 month post-op, we can still have some great tissue healing. And this patient is about at 2 months now. This was done at the Vistara course in at the end of the summer, in I believe end of July, not the end of the summer, but the middle of the summer. And she's about ready to go, and we should have her in soon. So if anyone's interested in seeing some future post-ops, I'd be happy to send them, and I include my email at the bottom, as well as you can contact me through Osteo News. You can see on the post-op there that everything's looking really well. The bone's starting to heal really well in the area at 1 month. And then this was at the 10-week. You can see excellent healing, excellent healing. We did switch out those healing abutments and made them slightly taller, and you can see things are moving along very, very, very well. So hope you enjoyed that presentation. I invite you to come to our seminars. We provide live surgical seminars around the world. We have our next one, I believe, in China. They are coordinated by our director, Dr. Samuel Lee of Harvard University, who is a MSc in periodontics at Harvard University, which is really an impressive institution, as you all may know. And he is a creator of many, many different implant techniques that I've used here today, as well as many sinus techniques. He is my sinus guru. And as you can see, I am one instructor. We have many instructors, and we teach various different techniques at these courses, including palatal implants and ridge splitting and even nerve lateralization in our courses. They are available in Mexico, as well as one that we had this summer in Chile, and the next one, like I said, is I believe is in China. So if you're interested in taking one of our courses, you can feel free to contact us through ce4dentist.com, and we'll get back to you about that. My next course is actually at Vistara. It is a ridge splitting course, and we'll be showing a case similar to the ones in those pictures. It is on Sunday, September 21st, and if you do live in the area, we invite you to come down. You can contact our Vistara facility or our Megagen representative, Natasha Schwartz, at the information listed on the bottom left. And lastly, I'd invite you all to attend the Megagen International Symposium, which will be in my hometown of New York. It is on May 1st and 2nd of 2015. It will be at the Grand Hyatt, one of my favorite hotels in the middle of Midtown Manhattan. And we should have a really, really great presentation there from many great dental implant instructors. I want to thank you for your time. As you can see, there is my email, isaactowelldds@gmail.com, and my website, toweldental.com, as well as my phone number. If you have any questions, again, you can feel free to contact me directly or through the Osteo News link on your webpage. I want to thank you all for your time and for allowing me to present this in your homes or on your smartphones in today's day and age. And I encourage any questions or comments or future case questions on anything you may have. Again, feel free to contact me. Thank you very much.